Dr. Jacob Aki.
Oh, my apologies, Doc.
I work for MEDITECH, and my responsibility there is corporate accounts and healthcare, long title, but my big responsibility is around particularly public sector. Largely because there's major challenges, and largely because it's quite important. I think in the private sector, quality is assumed. And in the public sector, you know you don't have it, and you keep talking about it. And yet we sometimes don't do enough. But at least the talking is in the sort of right direction. So somewhere between the two, we would hopefully sometimes find some progress. What I would cover is that these are not topics on the slides, these are themes. And they will cut across all slides. But I use the word conundrum because defining quality becomes ever so complex. And we'll go into details about it. And sometimes you think you have it until the next round of things you review and you realize that you're not exactly where you thought you would be because the technology has moved on, because the understanding of your patients has moved on, because of a whole lot of factors. And it's something that you'll continue to chase. I'll cover NHI. Really, it's broad strokes that I'm looking at, and those things that relate to quality, population health and how it relates to quality, actionable clinical data, care coordination, and again, linking it to quality, patient engagement, and it will link to the question that you asked about ownership of patients' clinical data. And in the end, it's about value. It's about what we deliver to our patients. Now, the critically important thing here is that we could use value to determine how much we pay. And I'm sure, Dr. Ray here is the only person I'm not scared of. Dr. Ray Bila is one of the people that I think probably would be the only Gucci communist here who would still, however, be worried about terms such as reimbursement. But the key thing about it is that how do you link that to quality going forward? From an NHI point of view, this is a complex thing that we're presented with. It is a happy place to be because it acknowledges the complexity of healthcare. It acknowledges that it's difficult to do anything. But in all of this, how do you place quality in there? And this is about the population that you cover. This is about the services that you render, how broad you are. And this is about financial risk protection so that anybody doesn't have to suffer serious financial harm as a result of ill health. But somewhere in there we've got to factor in quality, and it's something that I would discuss going forward. Why is it conundrum? Like I said, it's difficult to define. And you can pick up any of those definitions, and I'm sure you'll come with 100 more definitions. And sometimes we are happy to pick up one because at that space in time, the sixth dimension happens to fit my consulting model, and I'll use the six dimensions. And at some point, I would look at outcomes because, hey, what I sell tends to fit into the outcomes. But this is a complexity. But the important thing that is there is that quality is not equivalent to excellence. But however, it's an important part of excellence. The second part about it is that the solutions are complex. And this is thanks to adapted work from what work that PwC did a while ago. The key thing about it is that the responsibility and accountability goes to everybody. And quite often we would tend to say who's responsible, who's doing that. And less often we tend to say who can bring the best solutions. And sometimes if you do that, these things becomes a lot more easy. Role of government, and we will see it, without government there's no way that you can be able to do it. Otherwise what happens is that, again, coming to the ownership of the data, I own the data, I have it, anybody who wants to have it better pay some money. It's patient clinical data, it's lab results, you want to do research, how much are you willing to pay? And this is something that leads to, and that's a role that government must play. Patient engagement, increasingly becoming important. I think for a long time we have assumed that patients are recipients of whatever else that we do. And I'm talking this having been a patient just a few weeks ago. They are recipients of everything that we do. And suddenly you get to some point where, I think a few weeks ago, I really understood the difference as a doctor between discomfort and pain. When I do a procedure to a patient, I say it's going to be a little bit uncomfortable, but I know it's not discomfort, it's pain. And the key thing about it is that we haven't engaged our patients enough. The measurements, and this we can talk a whole lot about, particularly from a clinical point of view and integrating everybody. Again, this thing would be subject to a whole lot of debate. This is important from a cross-border point of view, and it's not just in the US, it's us here at home, about what disease profiles we have across the border in Botswana, in Zimbabwe, and later we've had disease outbreak that has made us to really reassess where we sit here. Strategic purchasing. Gone are the days where, and unfortunately it still happens, where somebody, an organization, and I won't mention names, send out a patient for tests and procedures for oncology, and all that they get back is an invoice. And gone are those days. And I'm hoping those organizations will realize that it's unsustainable. And quite importantly, information technology. You cannot enable a whole lot of this without the appropriate information technology to do it. But you've got a rising burden of disease. And in the public sector, one of the key things that is there that talks also to responsibility and accountability is that it doesn't matter how much technology you have. You still have hurdles around things such as policy. And I can tell you at some point it becomes insurmountable. I'll give you an example where it's possible to send a patient from a clinic, have the patient admitted at the clinic, get to the hospital, go straight to the bed, and have the clerk go and see the patient at the bed, and save to have another doctor, another nurse, and a whole lot of other people look after the patients. Now, the hospital manager who runs the hospital says, but that is my bed. I will not allow any outsider, however senior they may be, to admit the patient on my bed without me having some amount of control. And it becomes an important issue at the clinic saying, I will not do test ABC for this patient who's going to the hospital because I'm not funded for those. They are real problems, but that is the nature of the sort of things that you have to do, that in the end, the quality outcomes depend on a whole lot of those issues being solved. Now, it's quite important that it gets complex, isn't it? It was a nice, easy box, but now if you have to factor in quality into it, suddenly you realize that there's a whole lot of things. And World Health Organization very cleverly put it right at the top. But importantly, this doesn't mean it has to stay until the very last end. It's still the same cube, increased complexity, and this is only about quality and this, and you can feed a million other things in there, and all of them are moving parts that have to be addressed on an ongoing basis. Now, when you look at this thing, is that a whole lot of people say that cube, it may be a modern day magic cube that holds a lot of promise and enthusiasm and excitement at solving the riddle, but it may be this. A modern day Pandora's box, which if we dare touch, we're going to have problems. I think this is important, particularly from NHI, because without this thing, without IT, NHI won't happen. It's just basic fact, it won't happen. And the other thing is that done wrongly, we will unleash monsters that have been sitting in the healthcare systems for centuries. And those things becomes self-interest, becomes profits of organization, but if we look at it fundamentally, it also becomes employment of people. So however way you look at it, we should be very, very careful about how we deal with this. Now, how do we move there? Given the fact that we can't agree on all of those things. The key thing about it for me is that it's not simple, but it's very logical. Sorry, I'm still fiddling with this thing. Public sector do, and increasingly private sector, they do very well here. You've got reams and reams of books about protocols, about guidelines, about procedures. And I can tell you, I'm not too scared of Dr. Bila. He counts as my employer because I do still work for your hospital. Quite often you have those of us who says, it doesn't make clinical sense, I will not do it, even though it's there. And the good example about it is that if you like technology, you tell me not to do creatinine at 9 o'clock at night, and I'm saying if I don't do it, it's going to be done the next day, and this patient will stay 2 more days in the hospital because of that delay. You have saved, what, 20 rands? And what you incur is 4 or 5 days more in a hospital. It doesn't make sense. So it's pretty logical, it's not complex. And the idea really is that jumping from whatever inputs that we have to the outcomes, and this must include population as well, I would rather be doing this than this. And the idea is that we have opportunity now to be able to leapfrog. We have an opportunity to do things differently. Things that Western countries have taken a long time to do, we can achieve a lot more quicker. NHI mentions another issue which is over and above the quality issue that is mentioned more than 80 times there, is the issue of one day I'll learn how to use this thing. It's the issue of populations. Those of you that are involved in healthcare will remember from an HIV perspective how many times we have changed the story about who the target population was. And at some point we are looking at gay men, and at some point we are looking at intravenous drug users, and at some point the interesting thing is that the changes have been correct, but the changes have by far been delayed. We pick up patterns quite often years after things have evolved. And the critical thing about it is that what is it that we've got to put in place to be able to slice and dice population, to in real time be able to know what is evolving and be able to respond a lot more quicker. The sugar daddy story is not new. Somehow we're picking up to it only in the last few years. And the critical thing about it is that we quite clearly, because of lack of system, have listings. Look, this is an American slide. So, you can ignore the data. We don't have adequate data. But from a population health point of view, and this is quite important because if you look at where NHI is going to start, is that they look at populations that are at risk. They have decided that they do not want to fight with some of you that are sitting here and go for Aki and me that has got medical aid. They'll go for the disabled. They'll go for mother and child. They'll go for those that are unemployed at some stage. But they have decided which populations they want to do. But selecting which population and what you do at each population has become very fundamental, because you can be able to intervene at pinpoint accuracy. From a health promotion point of view, there is this stuff that we quite often miss out. It's missing out a flu vaccine in a patient who's asthmatic and have a history of lung disease. And ultimately, these are the sort of stuff that flu vaccine, very, very cheap, the outcomes in the end becomes very catastrophic. But it's also looking at those at risk, but also selecting what about those you want to monitor. Chronic disease management, what are your protocols, what do you monitor? The critically ill. Now, how much resources you put in each one of them will depend on your profile. But it's quite important that for the first time we are able to do, and thankfully, National Department is also looking at this. First thing is that be able to identify your populations. However way that you identify them, at the moment the information is very sketchy, but I think we have sufficient. Involve the care providers, involve the patients, involve at a population level. But at a clinical level, it's much more fundamental. And the idea is that it's taking those priority conditions. And we know that. Every hospital can rattle what they regard as the top 10 conditions that they're dealing with. Every province can do, identifying those conditions. In the end, there's supposed to be a line here. In the end, look at the evidence that support your interventions. In other words, what am I going to measure? How am I going to measure it? If I decide to take, for diabetes, for example, if I decided to take HbA1c, what is my measure of control? Is it reasonable to take 6.5 as a measure of control? Is it reasonable to take 9? And what is the difference between those? And the idea is that Organize and coordinate care. It is fundamental. It helps nobody when you've got all of this information, but however, you're not coordinating care. You know, old lady in the rural area has diabetes, it's unmanaged, but you have not put in place, and you can get the result, but you have not put in place the care coordination that is needed. You need to optimize your reimbursement because technology costs money, but you need to reinvest it. You need to continue to simplify the quality measures, make it easy, and we have realized that in other countries. Registries, create registries that allows you to be able to have the health coaches at a community level, disease managers, patient-centered medical homes. And we have remnants of this, that at the moment patients have got clubs from which they get their medication, from which they get their health education. So already you've got, at a policy level, some things that are starting to happen. But what you need to do is create registries and the support that allows you to be able to manage that. And those can range from chronic disease, wellness, but quite important that all of those things need to be supported by case management. How then, after doing that, how do you connect the dots? And the critical thing is understanding that it's not only you out there in the field. In other words, I may be MEDITECH, I may have bells and whistles here and there, but there's somebody else out there. And how do I get their data? How do I get their data in the system in such a way that I'm able, because collaboration in this industry, given where NHI is going, is inevitable. Nobody is going to be able to do it. In any case, healthcare is going that way. These are important, and I think what happens that our context is that a whole lot of people say, but in the public sector, nobody is going to be able to afford this. This is a different model that allows an individual person to own a device. The most common model in the public sector is probably going to be a community healthcare worker going with the gadgets, with a bag full of gadgets from home to home to home, and making sure that they collect the information. And that may be the best model to work. But if I live in Santen, I want my own gadget. And can I have it in pink? And the idea is that we've got the best of both worlds. We've got the worst of both worlds. And we need to be able to play within that advantage. Critically, condition-specific, it's being able to say, again, taking it, diabetes, what do I measure? Who's the doctor who's messing up, whose patients have got high level? And we'll look at it. Who's the doctor who, the last time this was done was so many days ago. And again, what happens is that this becomes the basis of your value-based purchasing. What do I pay for? Do I pay for value? Has he done what he needs to do? Now, our advice to the Department of Health is that risk-adjusted capitated model is a good start. But if I'm a GP and I suddenly get contracted to see these 250 patients who I didn't have before, why do I still need to go to work at 7 in the morning? I'm guaranteed. It's a risk-adjusted, but it's capitated. And the idea about it is that you want to incentivize the correct behavior. I'll go quickly. From wellness point of view, again, and understanding that wellness incorporates high blood pressure, incorporates cholesterol and all the other things, but you start playing around who is obese, where do I need to intervene? Event-driven registries that tells you who's accessed the system when, and the services when, and what was the reason for it. I'll go quickly through this chronic disease management thing. This is important. And again, what happens is that you then, you then start looking at performance at a particular clinic to say, how is this doctor comparing to the rest of the group? And in any case, if I have to pay that doctor based on performance, how do I adjust it based on this? When everybody else is performing relatively within the standard that I have set. And those are national standards that may have to be set. All that I'm saying is that the technology is there. We don't have to reinvent the wheel, but it is possible to start linking populations and good quality outcomes. It's possible to start looking at this and start saying who of this doctor needs to go for further training because they are giving us this stuff. Or amongst patients, who has been so badly managed in terms of his diabetes and is obese and smoke, and I can be able to send one person to that rural village to help manage a risk that would otherwise cost us significant amount of money in ICU. So critically what we're saying is that there is a lot that is happening. I'll go quickly. Again, ownership of patient data. The staff is there, and we're not unique in that. The staff is there. The critical part about your question is that I'm with Vodacom, and they've got all of these things, and they've got my glucose, and next time I go to cell C, how is Vodacom going to let go of my data? And the key issue there would be regulation. I'm a firm believer that the patient, first and foremost, must own the data. Government can be custodian. And again, what happens, technology allows within this environment to have one person or another person, or the medical manager in the hospital to have access to my phone, to getting whatever data that is there. The technology is there, so it's not unique. Again, how do we then get those devices and starting to talk? And it's quite important here that we start looking at patient-generated health data, and there's increasingly a lot of it. And how do we integrate it in the rest of the system? Key thing about it is this element that people fill papers that we conveniently decide to throw in the rubbish bin, and they can be able to give you feedback about how that service was. And the important thing about it is that you can make it as easy as you can or as complex as you can. But critical about patient-generated health data is that it must include the clinical details, the questionnaires, and I think Dr. Magaka and Rajiv Ishwari from KZN will be happy to say integrate telemedicine because money is being spent there. But the critical part about it is this. Having done all of this, collecting all of this, make that data actionable. Make it in such a way that Dr. So-and-so is bound to see the data and you can say whether or not he has done something about it. And if he hasn't done something about it, it needs to reflect on his performance. Make sure that you've got care plans for it. You cannot monitor obesity, you cannot monitor cigarette smoking, and not have a plan for it. Make sure that you've got case management. And suddenly, case management is not that person in the hospital whose function is to do ICD-10 and collect money. It's a clinical responsibility. And make sure that you link it to clinical registries that are integrated within the entire network. And importantly for me, is it achievable? Overwhelmingly, yes. I think this is important thing that the National Department of Health recognizes that there's going to have to be an overhaul. And lastly, you need a single electronic health record or interoperable electronic health record. But what is important as a last word from the Minister, it's an imperative. And the critical thing, and I would suggest any of you to go and look at the Universal Health Coverage 2030, big money is coming into it. So it doesn't matter whether we like it or not, it's coming, it's here. And I think those of us that are in the industry, we need to take heed of that, act with ambition. Thank you.
I have a prediction that there are going to be quite a few questions, so raise your hands if you have a question. But can I start with the first question? When you look at the current situation with regards to malpractice and how much it's costing the Department of Health, can the NHI succeed when you look at malpractice? And in particular, in the last 6 years, year on year, the claims that are being paid out are going up by 14, 15% a year. It's a massive problem, and you can't have the national healthcare succeed if you have that kind of amount of malpractice. What are your thoughts on that?
My thinking is this. It will actually increase without national health insurance. Implemented correctly. I want to give you just an example. I work at a public sector hospital. I won't mention which one. And I see the trauma unit, and I've got 50 patients, some of whom are drunk, some of whom are not, and most of them not very serious. You know, my neighbor hit me, clapped me, and I need to have a police force. Most of them not serious. But you have 10 or so patients that are very, very serious. Now, NHI implemented correctly for me is that I would like to take those 10, 15 patients that are not serious, send them to a private hospital where arrangements has been made and a fee schedule has been agreed to, so that I can focus on the very sick. So it's how you do it.
Yeah.
That's the first thing. The second thing about it is that because we don't have it, there are those populations that fall through the cracks. And the idea is that we pick up things way too late.
Yes.
But it's also one thing that's forcing governments to say, let's overhaul the system. And what National Department of Health is saying is that head offices are overstaffed. And all head offices will have to reduce and let go of the staffing so that they go to the clinical end. So my take is that without it, healthcare in South Africa is troubled, but public health will be even worse off because the litigations will increase.
And I suppose where you highlighted all the data that you were focusing on, I suppose that once you know where the problems are, you can start fixing them. I mean, you look at KZN, for example, the highest amounts of claims are coming from malpractice related to gynecological issues and obstetricians. That's where the bulk of the payouts are coming. So if you can say, well, this is what we're doing wrong, this is what these doctors are doing wrong, we can address those kind of issues. So I suppose there's the other side of it, that you have more control of everything.
I think what happens, what it forces us to do is that to use resources where they are. Now, if you're sitting in a public sector and you're literally in a labor ward catching babies, you're not doing proper management of obstetrics, you're catching babies as before. You're asking for trouble.
Yeah.
And your colleague a kilometer away is sleeping nicely and has only 2 or 3 patients to do that. So it gives us a platform around which we can collaborate and share risks and benefits in the healthcare system.
We've got a question over there, Doc.
Hi, Dr. Pua. Thanks for your presentation.
Dr. Poe.
Yeah, so so as this is quite ambitious, I think we need to just bring it back one step. The first thing is that when we want to build credibility for something like this, and I'll give you a very practical example. So at the hospital level, and I'm talking at the government level, we're not even getting to see what the caseloads are of those different hospitals. That data is available nowhere. So the problem with that is that you're designing a model for which you have no data. So that's the first problem. The second problem is that the government has an obligation for primary health care. So it's not everything, but it's the most important things. So when we talk about one of the pillars inside of that on the analytical model is not going to be there because we're not constructing the data. And 2025 for NHI to go live, we just don't have enough years in order to collate that type of data. It doesn't matter how many databases we're linking up through different technologies. So just to answer what you were talking about, Aki, one of the comments that you were making there, in the government strategy on the problem of people getting hospital care and then something happens, an adverse event happens, and then they get sued. We don't have the skill set in this country, unfortunately, in order to bring that statistic down. So one of the pillars of NHI is that telemedicine will come into the picture, where they will come in and bring in the skill remotely.
I'm just going to ask you just to be brief, because we.
So my question is this: how do we bridge that gap?
Yeah.
So the government has this primary care obligation.
Bridge the gap of data you're talking about.
That's it, because we're not going to make qualitative decisions otherwise.
But you are of the opinion that NHI has to happen. We don't have an option. Are you saying that NHI mustn't happen, or we've got the issues?
I can't see history.
No,
it's the best predictor. No, it won't happen.
I'm asking you if you think that we need to have NHI or not.
No.
Okay. I disagree with you, but I mean, we all have different opinions. But the thing is about the data. He makes good points, but I see you creating barriers. But I think if we all put our minds to it, it's something that we've got to do. We've got to make it happen. We can't continue anymore along this route.
Yeah. And it's also a question of where you start. You mentioned telemedicine. I think the 2 gentlemen that I've mentioned before, Dr. Magaka and Dr. Rajiv Ashwari, are doing some things in KZN. They have the technology that is happening, But what happens is that it's not integrated, even though they have a healthcare information system in the province. So it means there's a small little bit that's got to be done in between the two systems to make sure that they are interoperable.
Yeah.
That's the first thing. The second thing about government not being responsible for everything, I think we should dispel that myth. The reality is that government has taken on far much more than it's able to carry. And they have no choice because the Constitution says they have to. Now, the critical thing about it is not just primary health care, it ranges from the smallest of ailment right through to quaternary health care. So they have to. What's even more important is that from a funding model perspective, when you and I, medical aid, get exhausted, where do we go to? We go to government and we tell them we're unemployed. And the critical thing about it is that there is stuff happening. Now, you mentioned the lack of data. Look, it's quite clearly is a problem with that. But I like to be a little bit more practical. Again, with the permission from it, if they don't want me to speak, they must raise their hands, Dr. Magata and Dr. Ishwari. If you're looking at KZN and somebody has to drive 200 kilometers, a cancer patient arrives at the hospital, this patient is coming for chemo, and they say, gee, your hemoglobin is low. Go back to your hospital, get admitted for 2-3 days, get blood transfusion, and once it's done, come back. Now, what happens is that you've got NHLS in the rural areas where this person comes from. You've got a hospital with an information system. It is possible. So the big thing about it is that you're not going to do it one big jump at a time, but there are opportunities, there are things, there are possibilities, there are things that we can do now that will make a difference. And I think it's as we do those. And with regard to the lack of data, I hope there's somebody from NHLS, and I want to quote them as an example. They're sitting on a massive amount of data. It's not always the best kind of data in some areas, because when it comes to diagnosis, I don't code the diagnosis, I put whatever else that I can put. So if they can sort out the ICD-10 bit and allow me to be intelligent in what I put in there, it will improve the quality of the data. But what it means is that from a public sector, you've got a platform which, if appropriately enhanced, can improve that data without doing the big stories. Okay. So there are opportunities everywhere. I think we just have to look carefully where we start to work.
Okay. I'm looking around the room if there are any other questions. But I think that you both raise interesting points. And I think that it's something that government needs to address more seriously, is the collection of the data and connecting everything together, because that ultimately will make the whole process a lot more streamlined. If everybody knows and you avoid things like the patient that traveled 300 kilometers. I'm looking around the room. Is there any other questions? And we'll move to the next discussion. Any questions? No? Okay. Fantastic. Doc, thank you very much. It was interesting. I mean, it's an interesting debate, and I think that we can spend hours debating NHI, but, some agree, some disagree, but you make some good points, and I think there are some massive challenges as well, but I think that there aren't challenges that we can't overcome. Thank you very much. Give the doctor a round of applause, ladies and gentlemen.